Hello everyone and welcome to our module on breast cancer. Breast carcinoma is the most common cancer among women, and usually when women develop breast cancer, it's adenocarcinoma that derives from epithelial cells of breast tissue. Although breast carcinoma is the most common cancer in women, it's the second leading cause of cancer death behind lung cancer, which is number one. And largely, breast carcinoma is a disease of older women. It's very rare before age 25. The incidence increases after age 30, and the median age at the time of diagnosis is 62 years. And then finally, you should be aware that it's rare, but breast cancer can occur in men, and we'll talk a little bit about this at the end of this video. Let's talk about some of the risk factors for breast carcinoma. First of all, female sex is a major risk factor. 99% of cases occur among women. It's also a risk factor if a woman has a first-degree relative who had breast cancer. Age is a risk factor, and then there are a number of lifestyle factors associated with breast cancer. Two of the important ones are alcohol and smoking. Women are also at increased risk for breast cancer if they have increased exposure to estrogen over the course of their lifetime. So women who have early menarche or late menopause have more menstrual cycles and more exposure to estrogen from the ovaries. Obesity is also a risk factor because adipose tissue converts androgens into estrogens, so women who are obese always have high levels of estrogens in their body, and that raises their risk of breast cancer and also cancers related to the endometrium. And then breastfeeding is protective, so women who have breastfed during the course of their life have a lower risk of developing breast cancer, and that's because when women are breastfeeding, they don't ovulate. Another risk factor is the age at the first live birth. So women who have children when they are very young, before age 20, are protected and have a lower risk of breast cancer. And women who are older, over age 35 at the time of their first live birth, have a higher risk of breast carcinoma. So on your board exams, they like you to know the modifiable risk factors for breast carcinoma. There's nothing a woman can do about her age or family history, but all of the items shown in this slide are potentially modifiable. So obesity, alcohol consumption, and smoking are the major modifiable risk factors for breast carcinoma. Other risk factors are physical inactivity, the choice to take hormone replacement therapy. I talk about HRT in other videos, but estrogen-containing HRTs raise the risk of breast cancer. And then lastly, a woman's reproductive history is also considered a modifiable risk factor. Let's talk about the clinical features of breast carcinoma. So you should be aware that breast cancer is often identified in an early asymptomatic stage through screening with mammography, and we'll talk about this in just a minute. When not identified through screening, breast cancer in the early phases presents as a breast mass. And classic features of a cancerous breast mass are a mass that is hard and immobile and has irregular borders. Later in disease, as it progresses, you can have other findings like axillary lymphadenopathy or changes in the skin. And I talk about the workup of breast masses, including those that may represent cancer, in another video. Some women with breast cancer present with what's known as peau d'orange. It's also called inflammatory breast carcinoma. This refers to redness or erythema plus swelling of the breast, and the breast becomes dimpled similar to the skin of an orange rind. That's why it's called peau d'orange. This is a picture of what it can look like on the screen here. It can also be itchy or painful. So when a woman presents with a red swollen breast, it's often presumed to be a skin infection, but if she's treated with antibiotics, there will be no response. So a woman who has a red swollen breast like this and no response to antibiotics, that should raise concern that she may have underlying breast cancer. The cause of peau d'orange is tumor invasion of dermal lymphatic vessels. Basically, the lymph can't drain from the skin of the breast, and that causes it to become red and swollen. Any breast cancer that invades the lymphatic vessels of the skin can lead to this presentation, but in many cases it's a high-grade malignancy, and often it's associated with a poor prognosis. And so if a woman presents with skin findings consistent with peau d'orange, the next step in the workup is the same as the workup for any breast lesion. It usually involves diagnostic mammography plus or minus ultrasound, and I talk about this workup in the video on breast masses. Another way that breast cancer can sometimes present is as Paget disease. Paget disease refers to erythema at the nipple caused by an underlying malignancy. This is a picture of what it looks like here on the screen, and this is what can happen when cancer begins at the nipple and then spreads outward over the surface of the breast. Unlike peau d'orange, which involves the entire breast, Paget disease is a localized process around the nipple. It can cause redness, and it can also cause bloody nipple discharge. And unfortunately, it's often mistaken for eczema or contact dermatitis. It's not until it gets to an advanced stage that it's sometimes diagnosed as breast cancer. If you want to distinguish Paget disease from other causes of skin changes around the nipple, you can do a skin biopsy and it will show the presence of Paget cells. These are intraepithelial adenocarcinoma cells, and when you see Paget cells, then you know that the woman has a breast cancer. About 50% of cases of Paget disease have an associated palpable mass, but even if there isn't a mass present, follow-up testing is always done with mammography, and that's because about 50% of women with Paget disease will have a lesion on mammogram. And so if a woman presents like this and is found to have Paget disease and she has a palpable mass or a lesion on mammogram, then the standard workup is done for a mass or a mammogram lesion. In cases where a woman presents like this, but no mass is palpated and no lesion is found by mammography, then usually those women are advised to have either mastectomy or breast-conserving surgical therapy, which is surgery that attempts to conserve the breast but remove any tumor that is present. The reason these interventions are recommended is because once you take out the breast and examine all the tissue, most women with Paget disease will have ductal carcinoma in situ. We'll talk about DCIS in a little bit, but it's a very important pre-malignant lesion. And in addition, about a quarter of women with Paget disease will ultimately be found to have invasive cancer. And so because the likelihood of DCIS or invasive cancer is so high, once you make a diagnosis of Paget disease, even if you don't have a mass or a lesion on mammogram, usually the woman is advised to have mastectomy or breast-conserving surgical therapy. So that's a nice segue into breast cancer screening using mammography. So mammography is an X-ray technique that takes images of the breast, and the goal is to identify microcalcifications, which are calcium deposits that occur within malignant breast lesions. They're also seen in some non-malignant breast lesions, in particular fat necrosis and sclerosing adenosis are two breast lesions that can cause calcifications that are not malignant. So just because a woman has microcalcifications, it doesn't mean she necessarily has breast cancer, but a finding of microcalcifications on mammogram usually leads to a biopsy to determine whether the underlying cause of the calcium deposits is malignancy or something else. When we send asymptomatic women for a mammogram, this is called screening mammography, and when a woman has a breast mass or a breast lesion like peau d'orange and we send her for a mammogram, that's called diagnostic mammography. This slide shows a table from the White Coat Companion that summarizes the guidelines for breast cancer screening using mammography. This can be very confusing as a student or a learner because there are lots of different societies with different recommendations, but this slide summarizes the key points that you want to always keep in mind. So before age 40, the risk of breast cancer is low, and also the breasts are very dense, so they're difficult to image for mammography. So there are no major groups that recommend screening women with mammography if they are at average risk for breast cancer and they are under age 40. Age 40 to 50 is a gray zone. The guidelines vary by expert group. There is some evidence that screening mammography is beneficial, but there are also a lot of false positives in this group. So overall, what most clinicians do is what's known as a shared decision-making model, where they discuss the pros and cons of breast cancer screening through mammography with the patient and come up with a shared decision on whether or not mammography will be done. Age 50 to 75 is where mammography is very helpful. The risk of breast carcinoma in this group is fairly high, so screening is generally recommended for all women every 2 years, although the frequency is debated and varies between expert groups. Some say every 1 year, some say every 2 years, but nevertheless, screening is generally recommended for women in this age group. And then beyond age 75, screening with mammography becomes less beneficial because life expectancy is shorter in this age group. So in general, mammograms are not indicated unless the patient is thought to have a life expectancy beyond 10 years. And in the video on breast masses, I talk about the standard BI-RADS reporting system for mammograms that radiologists use, and I talk about how to interpret the results of a mammogram to decide whether or not a woman needs a biopsy. There are two major types of breast carcinoma, the ductal type and the lobular type. The ductal type resemble duct cells from the breast, and the lobular type resemble lobular cells from the breast. That's how they get their name. In reality, both types of breast carcinoma derive from what's known as the terminal duct lobular unit, which is the unit of the breast that produces milk. And then carcinoma can be in situ or invasive. In situ carcinoma means the malignant cells are limited by the basement membrane and have not broken through. Invasive carcinoma has broken through the basement membrane and from there can spread beyond the breast. So sometimes when a woman has a breast biopsy, you do not identify invasive carcinoma, but you do identify a pre-malignant lesion. And it's important to understand what these are because actions have to be taken to prevent the woman from developing breast cancer. These lesions are also called proliferative lesions with atypia. They represent growths of breast tissue, that's why they're called proliferative, and they have atypical cells, meaning cells that are abnormal. And so when any of these lesions are identified, the woman has a significantly increased risk of subsequent breast cancer, and actions have to be taken to protect her from developing breast cancer. The three major premalignant lesions are ductal carcinoma in situ, lobular carcinoma in situ, and atypical hyperplasia. So ductal carcinoma in situ, or DCIS, is a malignant growth of epithelial cells of the terminal duct lobular unit. The cells fill the ductal lumen, but their growth is limited by intact basement membranes. That's why it's called in situ. This is a picture of DCIS on the screen here, and you can see the malignant cells are contained by basement membranes. This type of growth forms microcalcifications, so it's often detected on mammography, and then a biopsy is done and the biopsy identifies DCIS. And there are many subtypes based on the histology that you see on biopsy. On the screen is an example of the cribriform subtype of DCIS, but there are many others. DCIS is a malignant lesion, and when a woman has DCIS in the area of a biopsy, she very likely has it elsewhere in the same breast. And so the treatment has to involve treating the entire breast, either mastectomy, which is removal of the entire affected breast, or breast conserving therapy. Breast conserving therapy means lumpectomy, which is removal of the area of the breast with the DCIS, plus radiation therapy. Usually the lumpectomy is done with a sentinel node biopsy, which is a lymph node biopsy. We'll talk about this later. And the surgeon checks the margins to be sure that he or she has removed all of the DCIS. If the margins are positive, meaning they show DCIS, then usually re-excision is required in order to make sure you got all of the abnormal cells of DCIS. And then about 75% of cases of DCIS express the estrogen receptor or the progesterone receptor. We'll talk about this later. But in these cases, chemoprevention is done with agents that block growth of estrogen receptor positive tissue in the breast. LCIS is lobular carcinoma in situ. These breast lesions are a proliferation of cells from the ducts and lobules, but once again the growth is in situ, so it's limited by an intact basement membrane. At a cellular level, LCIS is sort of famous for a phenomenon called discohesive growth. This means the abnormal cells have loose intracellular connections, and this is because they don't express the adhesion protein E-cadherin. This is a picture of what lobular carcinoma in situ looks like on the screen here. You can see that there are these round cells clumped together. They're clumped together because the basement membrane remains intact. It's important to know that LCIS does not lead to microcalcifications, so this breast lesion is not going to be identified by mammography. Usually it's an incidental finding, so a woman has a biopsy because of a breast mass or some other suspicious finding on mammography, and an incidental finding is made that the woman has the presence of LCIS in her breast tissue. Often LCIS is bilateral and often it's multifocal, so when you see it on a biopsy, you can presume that it's also present elsewhere in the breast and in the opposite breast. The thing to know about LCIS is that even though it's called carcinoma in situ, that's actually kind of a misnomer because LCIS is not an invasive lesion. The importance of LCIS is that when it's identified, it's a risk factor for invasive carcinoma. Women who have LCIS on a breast biopsy have an increased risk of developing carcinoma later in life in either breast. So this is different from DCIS, which truly is a malignancy that, if left unchecked, would grow and become a carcinoma. LCIS is a marker for a woman whose breasts have a high risk of developing breast cancer. There are two subtypes of LCIS based on histology, the classic and the non-classic form. And for women who have the classic form, the treatment is surveillance and chemoprevention. So this is different from DCIS, where the woman usually has a mastectomy or radiation therapy to the entire breast. That's not the case here because really what you're managing is simply risk of carcinoma down the road in a woman's life. So women usually have annual mammograms and twice yearly breast exams. They should stop oral contraceptives and avoid hormone replacement therapy because these things can stimulate breast growth. And women are usually treated with SERMs or aromatase inhibitors. This is called chemoprevention, and we'll talk about these drugs later in this video. The non-classic form of LCIS is a little bit different. It's a little bit more dangerous. So if you identify this by biopsy, that's not the end of the workup. Usually the woman has to have a surgical excision to make sure that the entire non-classic LCIS lesion is removed. And then the final proliferative lesion with atypia is called atypical hyperplasia. There are two subtypes, atypical ductal hyperplasia and atypical lobular hyperplasia. And just like LCIS, atypical hyperplasia is often an incidental finding on biopsy for other reasons. It doesn't usually produce microcalcifications. And also, just like LCIS, this lesion is not malignant in and of itself, but when you identify this on biopsy, that woman has a substantial increase in her risk of developing subsequent breast cancer. This is a picture of what atypical ductal hyperplasia looks like on the screen here. And so when this is identified, it's not a malignant lesion. So unlike DCIS, you don't have to do a mastectomy or radiation, but you do want to employ risk reduction strategies to lower that woman's risk of developing a subsequent breast cancer. So what's usually done are annual mammograms, twice yearly breast exams, stop oral contraceptives, and avoid HRT, just like we talked about for LCIS. And then you can consider treatment with a drug like a SERM or a aromatase inhibitor. And once again, we'll talk about these things later. Okay, so now that we've talked about pre-malignant lesions, let's talk about invasive breast cancer. And we'll start by discussing invasive ductal carcinoma, which is the most common type of invasive carcinoma, responsible for about 80% of cases. The diagnosis is made through biopsy, which will show ductal cells with stroma that have broken through the basement membrane. Most commonly, this form of invasive carcinoma develops in the outer quadrant of the breast. So if this is a woman's midline and this is the lateral area, about half of cases develop out here, and that's because there's more breast tissue in this area of the breast. The treatment is based on the TNM stage of the carcinoma. We'll talk about this in a minute. And treatment can involve surgery, chemotherapy, or hormone therapy. The other type of invasive carcinoma is invasive lobular carcinoma. In this form of carcinoma, the cells grow in a single file, and that's because they've lost that E-cadherin adhesion protein, which we talked about earlier. Loss of this protein is seen in cells of lobular carcinoma in situ and also invasive lobular carcinoma. So because they've lost this protein, the cells cannot stick together in clumps, so you get cells growing in lines like what's shown in this image on the screen. Often lobular carcinoma is bilateral with multiple lesions in both breasts, and the treatment is based on the TNM stage of the tumor, which we're going to talk about in a second, and it also involves surgery and chemotherapy and hormone therapy. So in terms of prognosis of breast carcinoma, the most important prognostic factor is the presence or absence of axillary lymph node metastases. Breast cancer spreads first to the axillary lymph nodes, and then from there it spreads out to the body. So if these nodes are free of cancer, the woman has a much better prognosis compared to patients in which there is evidence of cancer in the axillary lymph nodes. To determine whether cancer has spread to the lymph nodes, a biopsy of the lymph nodes has to be done, and usually the way this is done is through what's known as a sentinel node biopsy. So what the surgeon does is inject a tracer into the area around the tumor, and that tracer will go to certain lymph nodes. Those are called the sentinel nodes. And the surgeon will dissect only those nodes, and if they're cancer-free, the surgeon can stop. If the sentinel nodes have evidence of metastases, then the surgeon will take out more nodes. And the idea here is that by doing a sentinel node biopsy, you can take out less lymph nodes. Before we did sentinel biopsies, women had to have multiple nodes taken out, and often all of them were free. Now we can just start with the sentinel nodes. If those are free of cancer, the surgeon can stop the procedure. Breast carcinoma is staged through the TNM system. TNM stands for tumor, node, and metastases. So according to this system, there are a whole bunch of stages. I've shown them here in this column. They go from stage 1 with substages like 1A and 1B all the way up to stage 4. Stage 4 carries the worst prognosis, and to be stage 4 you must have metastases beyond the lymph nodes. And then stages 1 through 3 are determined by the tumor size and the number of lymph nodes that are involved. The larger the tumor and the more nodes, the higher the stage is going to be. And so there are lots of tables where you can take a particular patient's tumor size and number of nodes with disease and plug it in and get the stage shown in this column here. So for example, if the tumor size was a 1 and there were no lymph nodes positive and there were no metastases, then the table would tell you that that patient is a 1A. And there are similar criteria for 1B, 2A, 2B, and so on. Let's talk about tumor markers, which are also important for prognosis, but they also help determine therapy. These are less important than the TNM stage, but they are still relevant in determining a woman's prognosis. So there are 3 important tumor markers that may or may not be expressed by a breast carcinoma. One is the estrogen receptor, the second is the progesterone receptor, and the third is the human epidermal growth factor receptor 2. So after a biopsy or after a surgery to remove a mass or even the entire breast, the tissue can be tested to determine whether the cancer cells are ER positive, PR positive, or HER2 positive. For women with breast cancers that express the estrogen receptor and the progesterone receptor, these women are candidates for chemoprevention, which is also known as endocrine therapy. Chemoprevention involves using oral drugs that block the effects of estrogen on receptors in the tumor. One of the drugs that can be used is tamoxifen. We'll talk about this drug in a second. It's a selective estrogen receptor modulator, or SERM. The other group of drugs used for chemoprevention are the aromatase inhibitors, and we'll also talk about these in just a minute. And in the majority of breast cancers, there is concordance between positivity for the ER and PR receptors. And what I mean by this is usually tumors are either positive for both receptors or negative for both receptors. There are a small number of tumors which are positive for one but negative for the others, and those are a special case I won't talk about in this video. For women who have tumors that express the HER2 receptor, these cancers may respond to the drug trastuzumab. We'll talk about this drug in a minute. It's an infusion therapy. It's not an oral drug like chemoprevention. And trastuzumab is a monoclonal antibody targeting the HER2 receptor. And then there are some women who have tumors that are called triple negative. These tumors do not express either the ER receptor, the PR receptor, or the HER2 receptor. These tend to be highly aggressive cancers, and they're more common in younger women, often women under age 40. So let's talk about the drugs used for chemoprevention, and we'll start with tamoxifen. Tamoxifen is a selective estrogen receptor modulator, also called a SERM, and the way it works is it's a competitive antagonist of the breast estrogen receptor, so it's useful in ER-positive breast cancers. Even though it's an antagonist of estrogen receptors in the breast, it functions as an agonist in other tissues like the bone and uterus. That's why it's called a selective modulator. And this is the preferred drug for chemoprevention in premenopausal women. We'll talk about this in a minute, but in premenopausal women, aromatase inhibitors are not effective. And so in women who have not yet entered menopause, who have ER-positive breast cancers, tamoxifen can be used for chemoprevention. Tamoxifen has some adverse effects, and it's high yield to know about these for your boards. First of all, it commonly causes hot flashes, and it does this through the same mechanism by which women get hot flashes at menopause. That's through decreasing estrogen effects in the body. It also increases the risk of DVT and PE, and that's because tamoxifen has some estrogen agonist effects, and one of the positive effects of estrogen is to increase the amount of clotting factors. So just like women on birth control have a higher rate of DVT or PE from estrogen, the same thing happens with tamoxifen. And then it's super high yield to know that tamoxifen is a partial agonist at the endometrium, so it's going to drive endometrial proliferation and growth. This can lead to endometrial hyperplasia. It can lead to polyp formation. Up to a third of women develop endometrial polyps while taking tamoxifen. And women who take this drug have a higher rate of endometrial cancer. And so when women are taking tamoxifen, they're often closely monitored for development of endometrial hyperplasia or carcinoma. The guidelines for this vary, but many women will have routine ultrasounds and pelvic exams, and sometimes even endometrial biopsy to exclude the development of hyperplasia. The other group of drugs used for chemoprevention are the aromatase inhibitors. There are a number of drugs in this class. Some of the commonly used ones are anastrozole, letrozole, and exemestane, and these drugs are used for ER-positive breast cancers among postmenopausal women. These drugs have been shown to be more effective than tamoxifen in clinical trials. They work by blocking the peripheral conversion of androgens to estrogens. Importantly, however, they're not used in women who are premenopausal. In premenopausal women, tamoxifen is the drug of choice. And the reason is that these drugs don't have much of an effect in high estrogen states. Before menopause, there is so much estrogen coming from the ovaries that these drugs don't have much impact. After menopause, most estrogen comes from adipose tissue where androgens are converted to estrogens. So in that setting, if you inhibit this conversion, you can dramatically decrease the amount of estrogens in a woman's body. These drugs do have some adverse effects, and one of the important ones for you to know about is that they raise the risk of osteoporosis from loss of estrogen effects, and therefore they increase a woman's risk of fracture in the postmenopausal state. Trastuzumab is a drug that goes by the trade name Herceptin. It's a monoclonal antibody against the HER2 receptor. HER2 is a surface receptor, and when it's activated, it leads to cell growth and proliferation, and HER2 is overexpressed by some breast cancer cells. So in women who have HER2 positive breast cancer, this drug has been shown to improve survival. The major toxicity of trastuzumab, and this often comes up in board exams, is cardiomyopathy. Many women taking this drug have a fall in their left ventricular ejection fraction. It's often asymptomatic. It's rare for this drug to cause heart failure symptoms, although it can happen. And so because of the risk of cardiomyopathy, before starting this drug, women always have an echocardiogram, and then they have serial echocardiograms over the course of their therapy with trastuzumab. And you may know that there are chemotherapy drugs used in the treatment of breast cancer called anthracyclines, and these drugs can also cause cardiotoxicity just like trastuzumab. But the cardiotoxicity from the two different treatments is very different. So trastuzumab causes cardiomyopathy, but it's not a dose-dependent effect. So with anthracyclines, the higher the dose you give, the more likely the patient is to develop cardiotoxicity. That is not true of trastuzumab. It's an idiopathic effect that either occurs or does not occur. Also, the cardiomyopathy of trastuzumab is often reversible when you stop the drug, and that is not always the case for anthracyclines. Anthracycline cardiotoxicity is a more serious problem, and it often persists after the treatment is stopped. And so if a patient on trastuzumab develops cardiomyopathy, you can stop the drug, let the left ventricular function recover, and then you can sometimes re-challenge the patient if they really need to receive trastuzumab. In the case of anthracyclines, once a patient develops cardiotoxicity, in many cases, we permanently discontinue those drugs and do not try them again. Let's talk briefly about familial breast cancer, which is responsible for about 10% of breast cancer cases. And in many cases, familial breast cancer is related to gene mutations in either the BRCA1 or BRCA2 genes. These genes are called BRCA because they were initially described in families with high rates of breast cancer. The BRCA1 and BRCA2 genes code for DNA repair proteins, and mutations in either gene are associated with an increased risk of developing breast cancer. Besides breast cancer, BRCA1 and BRCA2 gene mutations are associated with other malignancies as well. In particular, the BRCA1 gene mutation is associated with a higher rate of ovarian cancer, and in families with the BRCA2 gene mutation, there's a higher rate of male breast cancer and also pancreatic cancer. Both genes are transmitted in an autosomal dominant fashion, but they have incomplete penetrance. And what this means is that not all individuals with the disease mutation are going to develop disease. And so because of this phenomenon of incomplete penetrance, genetic counseling in families with these mutations is difficult because someone who has one of the gene mutations may or may not necessarily develop cancer in the future. And then I'll finish with one slide on male breast cancer. Male breast cancer is much less common than female breast cancer. The incidence is 1% compared to that of women. Usually male breast cancer occurs in older men. The typical age range is 60 to 70 years. And usually it presents as a subareolar mass beneath the nipple, sometimes with discharge. And the reason for this is because most breast tissue in males is near the nipple, and so that's where a mass usually occurs when male breast cancer develops. And so this is a very rare condition. You're unlikely to see it clinically, but there are two key associations you should know for your board exams in regards to male breast cancer. The first is Klinefelter syndrome. So men with Klinefelter syndrome usually have an extra X chromosome. They tend to be very tall, and they have hypogonadism, and they also have an increased risk of male breast cancer. And men with Klinefelter syndrome are responsible for about 3 to 8% of cases of male breast cancer. And then as I mentioned on the last slide, in families with the BRCA2 gene mutation, men in those families have a higher risk of developing male breast cancer. And so men with BRCA2 gene mutations are responsible for a significant number of male breast cancer cases, about 4 to 14%. And that concludes our module on breast cancer.